Welcome to Fireside Chat with Beth and Matt, your go-to podcast for decoding radiology articles. Today we explore a groundbreaking update to first-trimester ultrasound terminology that's changing how we report, communicate, and care.
It really is fascinating, isn't it, how the specific words we choose in medicine can have such a big impact.
Definitely, and especially with early pregnancy ultrasound. It's so common.
Exactly, whether it's just confirming the pregnancy, getting the dates right, or looking into bleeding or pain, it's done all the time.
But despite that, and despite having guidelines from different societies, especially around pregnancies that aren't progressing.
The language hasn't been consistent. That's the surprising part.
Right, so many terms were kind of vague or used differently by different people or just sort of evolved over time without clear definitions.
And that inconsistency really matters, you know?
Okay, let's unpack that. Why is it such a big deal?
Well, think about the patient first. More and more, people have instant access to their medical records, their reports.
Yeah, through patient portals and things.
Exactly. So imagine getting a report with terms that are unclear or maybe even outdated. It can cause a lot of unnecessary worry, confusion.
That's a huge point about the patient experience. And it goes beyond just individual anxiety, doesn't it? There's a bigger picture.
Absolutely. You have to consider how medical language might be, well, interpreted or even used in other contexts, especially in sensitive areas.
Like the legal or political sphere?
Potentially, yes. The language in our reports could be viewed through different lenses, so having really precise, scientific, medically appropriate language is crucial. It helps protect that fundamental doctor-patient relationship.
So who kicked off this big update? Who decided we need to standardize things?
That initiative came from the Society of Radiologists in Ultrasound, the SRU. They saw this need for clarity.
And what do they do?
They put together a multi-society panel bringing in experts from various fields related to early pregnancy.
Okay.
And the goal was to create this new first-trimester ultrasound lexicon, something based firmly on evidence, on the existing guidelines, and importantly, on expert consensus.
And it's not just for radiologists, right?
No, definitely not. It's aimed at imagers, yes, but also all the clinicians involved, OBGYNs, emergency docs, family medicine, and, crucially, keeping in mind how patients perceive and understand these terms.
Makes sense. So what were the main goals? What did they want this lexicon to achieve?
They were aiming for several things. Terminology that's clear, specific, scientifically accurate, and appropriate for clinical use.
Okay.
And also terms that would be widely accepted and understood by everyone involved. Radiologists, clinicians, patients. And really importantly, language that minimizes potential bias or harm.
That sounds like quite a task. What specific areas does this lexicon cover? What's in and what's out?
It's pretty focused. It tackles terms that are unique to and commonly used in the first trimester, so up to 13 weeks and 6 days gestational age.
Right.
It deliberately leaves out things like multiple gestations, twins, triplets, or detailed fetal anomalies, gestational trophoblastic disease.
Like molar pregnancies?
Exactly, and also general descriptive terms that aren't specific to pregnancy, like, say, corpus luteum.
Got it. So it keeps the scope manageable. How is it organized? What are the main sections?
They broke it down into 4 main categories, which makes it pretty logical to follow.
Okay, what are they?
First, there are general first trimester terms. Second, terms related to early development, how things look as they grow. Third, terms about pregnancy location. And fourth, terminology for early pregnancy loss.
Excellent. That gives us a good roadmap. Let's dive into that first category. General first trimester terms. What are the key things here?
Well, one basic thing is just defining pregnancy itself based on HCG levels, human chorionic gonadotropin.
Right.
The consensus is that pregnancy is defined by a serum HCG level over 5 MIU/mL. They do note that labs might use slightly different assays and that some are moving away from calling it beta HCG.
Okay.
And it's worth remembering, though it's rare, that you can sometimes see elevated HCG for reasons other than pregnancy.
Good point. So HCG is the starting point. But with those caveats, what about figuring out the age of the pregnancy? Gestational age or GA?
Yeah, that's fundamental. They confirm the standard ways, calculated from the first day of the last menstrual period, or based on measurements from an early dating ultrasound. It's reported in weeks and days.
And sometimes called menstrual age.
Right, or clinical dates. But they specifically mention that dating for pregnancies from assisted reproduction, like IVF, is outside the scope of this lexicon.
Understood. Standard dating methods are covered. And how long is the first trimester, according to this?
Clearly defined, up to and including 13 weeks and 6 days of gestational age.
Okay, 13 and 6. Got it. Now, what's about using the word normal in our reports? That seems like it could be tricky.
It really can be, and they address this directly. The Lexicon says normal should really only be used to describe the ultrasound examination itself, like a technical quality or the location of the pregnancy.
So normal first trimester U.S. exam is okay.
Yes, or normal intrauterine location. But, and this is important, they strongly advise against saying normal first trimester pregnancy.
Why is that?
Because even if everything looks typical for that early stage, there could still be an underlying abnormality that just isn't visible yet on ultrasound. So calling the whole pregnancy normal could be misleading or give false reassurance.
That makes a lot of sense. It manages expectations.
Yeah.
And the last general point, what we actually call these scans.
Yes. The recommendation is to use first trimester US or early pregnancy US.
Am not.
And specifically not to call it a viability scan. We'll get more into why when we talk about cardiac activity and loss, but it sets up an expectation that might not be accurate yet.
Okay, that sets the stage well with the general terms. Let's move to the second category, early development, what we see growing in those first weeks.
Right. This section really draws on the AIUM, the American Institute of Ultrasound and Medicine Practice Parameters. It's about what we visualize, the gestational sac, the yolk sac, the embryo, and whether there's cardiac activity.
Makes sense.
An important note here is about twins or multiples. If you see just one gestational sac very early, before you can see an embryo inside, you should just report a single gestational sac. Don't jump to calling it a single pregnancy because it might turn out to be twins later when the embryos become visible.
Good point. Keep it descriptive.
And all these descriptions assume we're using transvaginal ultrasound, which gives us that much better detail early on.
Of course. So let's start with the sex gestational sac and yolk sac, the earliest signs.
The gestational sac, the GS, is usually the very first thing we see, maybe around 5 weeks GA. It looks like a fluid collection, typically round or oval, and it has this bright hyperechoic rim around it.
Okay.
Then, maybe half a week later, around 5.5 weeks, the yolk sac often appears. It's a small circular structure with a thin rim, usually off to one side within the GS, and less than 6 millimeters across.
And seeing that yolk sac is key.
It really is. If you see a yolk sac inside a fluid collection within the uterus, that confirms it's a definite gestational sac or a definite pregnancy.
And what if you see that fluid collection, that sac-like structure, but no yolk sac inside yet?
In that case, it's still very likely an early pregnancy, but it's not quite as certain. The Lexicon recommends calling that a probable gestational sac or probable pregnancy.
Okay, so definite with a yolk sac, probable without. Makes sense. What about other signs people sometimes mention, like the introdecidual sign or the double decidual sign? Do those matter?
They can be helpful, yes. Seeing those signs when you have an empty appearing sac can increase your confidence that it is an intrauterine pregnancy.
Right.
But they aren't always present, so their sensitivity is lower. And there's some variability in how reliably different people identify them. So while useful if you see them, they aren't required to diagnose an IUP.
Got it. Helpful, but not essential. Now, there's a strong recommendation against using the term pseudosac. Why is that?
Yes. This is really critical for safety. Sometimes you can get fluid collecting in the endometrial cavity, maybe in a patient who actually has an ectopic pregnancy.
Right.
And that fluid might look a bit like a gestational sac. In the past, people called this a pseudosac or pseudogestational sac.
But that's discouraged now.
Strongly discouraged. Using those terms is risky. You might mistake it for an ectopic, or worse, dismiss an actual early IUP.
So what should we say instead?
Just describe what you see. If it's fluid in the cavity, maybe with pony edges or some echoes inside, call it intracavitary fluid or fluid in the endometrial cavity. Be descriptive, not interpretive with a potentially misleading label.
Okay, clear description is safer. Good. Moving on to the embryo and fetus. When do we switch terms?
They provide a clear cutoff based on gestational age. It's an embryo up to and including 10 weeks and 6 days GA.
And then?
From 11 weeks and 0 days onwards, you use the term fetus. This aligns with how we usually count completed weeks of pregnancy.
10 and 6 is the embryo limit. 11 and 0 starts the fetus. Easy enough.
Yeah.
And they want us to stop using the term pole.
Yes, exactly. Terms like embryonic pole or fetal pole are considered obsolete. They should not be used anymore.
So what do we use for measurement?
When you can measure the embryo or fetus, you use crown rump length or CRL. That's the standard measurement, the longest straight line length.
And that's better for dating.
Once the embryo is measurable, yes, CRL becomes more accurate for dating the pregnancy than just measuring the mean sac diameter.
Okay, ditch pole, use CRL. Got it. Now, a really sensitive area describing the activity, the heartbeat. What's the right language?
This is a key area for precise and sensitive language. For those rhythmic pulsations we see, the recommended term is cardiac activity.
Not heartbeat or heart motion.
Right, or you could use cardiac motion as an alternative. Terms like heart motion, heart activity, or heartbeat are discouraged.
Why the change?
Because heart implies a fully formed, four-chambered organ, which isn't anatomically correct in the very early stages. Cardiac is more accurate scientifically, and it's also the term ACOG endorses.
Makes sense. And how do we report it?
You should report the rate in beats per minute, and ideally measure it using M-mode ultrasound.
Okay. Now, what about using words like live or viable? Those seem common.
They were, but the Lexicon strongly advises against using live, living, and viable in the first trimester.
Why is that? Seems like a big change.
There are a few reasons. First, these terms can be easily misinterpreted, maybe taken out of context, especially in non-medical discussions.
Oh, okay.
Second, they can create unrealistic expectations for patients, especially if the pregnancy outlook is uncertain, like with a potential loss or an ectopic.
Right.
And technically, fetal viability usually refers to the ability to survive outside the womb, which just doesn't apply in the first trimester.
So avoid live, living, viable. What about non-viable?
Also recommend avoiding non-viable and the phrase pregnancy of uncertain viability.
Which connects back to not calling it a viability scan. Right?
Exactly. It frames the scan more neutrally as descriptive, first trimester US, rather than predictive viability scan at a stage where things can still be uncertain.
That's a really thoughtful change. Okay, last thing in this section, the amnion.
Right, the amnion. That's the thin membrane we see surrounding the embryo or fetus inside the gestational sac. It usually becomes visible around 7 weeks GA.
And the space inside it.
That's the amniotic cavity, filled with amniotic fluid.
Okay, that covers early development well. Let's shift to the third category, pregnancy location. Super important, obviously.
Absolutely critical. The Lexicon groups locations into 3 types: normal, abnormal, and unknown.
Let's start with normal. What defines a normal location?
A normally located pregnancy is what we usually call an IUP, intrauterine pregnancy. It means it's implanted in the typical spot within the upper 2/3 of the uterine cavity.
Okay, standard IUP.
But they clarify something important. Even if a pregnancy is technically inside the uterus, if it's in an abnormal spot like the cervix or a C-section scar, or if it's clearly moving down towards the cervix during an expulsion, those are not considered normally located, even though they're intrauterine.
That's a key distinction. Are there other terms for a normal IUP?
You could also say normally located pregnancy or normally located IUP.
What about when an IUP looks like it's implanted off to one side, but the uterus itself is normal, sometimes called angular?
Right. That used to be called angular or sometimes cornual pregnancy. But those terms are confusing and should be avoided because they can be mistaken for an interstitial ectopic.
So what should we say?
Just report it as an IUP. If you want to be more descriptive, you could say an eccentrically located gestational sac completely surrounded by endometrium, and conclude it's an IUP.
And if you're still not sure?
A quick follow-up scan or maybe a 3D coronal view can help make sure it's not an interstitial EP.
Good advice. Be precise to avoid confusion. What if the uterus isn't anatomically normal, like a bicornuate uterus?
In those cases with Mullerian duct anomalies, you describe the location relative to the anomaly.
So instead of cornual pregnancy in a bicornuate uterus,
you'd say something like, gestational sac is normally located in the left horn of a bicornuate uterus. Be descriptive about the anatomy. Avoid ambiguous terms like cornual, bicornuate, or unicornuate pregnancy.
Clear, descriptive, anatomical. Got it. Now for the abnormal locations, ectopic pregnancies. Obviously high stakes here.
Extremely high stakes. Untreated EPs can lead to serious harm, even death. So accurate, timely diagnosis is vital.
And the term is still ectopic pregnancy, or EP.
Yes, EP is the standard term. But the Lexicon provides a very specific definition. An EP is any pregnancy implanted in an abnormal location.
Any abnormal location.
Yes, whether that's outside the uterus, extrauterine, or even within the uterus, but in an abnormal site. And importantly, this now includes cesarean scar pregnancies as a type of EP.
That's a significant clarification. CS scar pregnancies are now officially under the EP umbrella. How should we report them?
Always state the specific location first, then EP. So tubal EP, cervical EP, cesarean scar EP.
And what are the possible locations?
The main ones are tubal, interstitial, where the tube enters the uterus, cervical, cesarean scar, ovarian, abdominal, and even intramural within the uterine wall.
Okay. Do we need to say where in the tube?
You can subclassify tubal EPs like isthmic, ampullary, but it's optional as it's not always easy to tell precisely on ultrasound.
And what else should be in the report?
Definitely mention if you see a yolk sac, embryo, fetus, or cardiac activity that helps with treatment planning. And note the side, left or right, if possible.
Can we use probable and definite like we did for IUPs?
Yes, same principle. Probable EP if you see suggestive findings, but no yolk sac or embryo. Definite EP if you do see a yolk sac or embryo.
And still avoid live or viable.
Absolutely. Crucial to avoid live, living, and viable when describing cardiac activity in an EP.
And we should remember heterotopic pregnancies, too.
Yes, that rare but important possibility of having both an IUP and an EP at the same time, especially with fertility treatments.
Okay, that's a great overview. Let's dig into some specifics. Tubal EPs are the most common, right?
By far. The usual finding is an adnexal mass, separate from the ovary. It can look different, variable echogenicity, maybe vascular. If you can't see the ovary separately, you could say extravariant mass.
Or sometimes we see a tubal ring.
Exactly. That looks like a little fluid collection with a thick, bright rim in the adnexor. That's the gestational sac in the tube. You could also call it an adnexal ring or adnexal GS.
But no slang terms.
Right. Avoid things like blob, bagel, or donut sign in the report.
So if you see that adnexal mass or tubal ring and no IUP,
It's highly likely to be a tubal EP.
how do we tell it apart from a corpus luteum cyst? They can look similar sometimes.
That's a classic challenge. Both can have that ring of fire vascularity on Doppler, so color flow isn't always definitive.
So it helps.
The tubal ring often has a brighter, more echogenic wall than a corpus luteum. Look at the relationship to the ovary. Is it clearly inside the ovary? Can you see the ovarian tissue clawing around it? That suggests corpus luteum.
And the sliding sign.
Yes, that's useful. If you gently push with the probe, does the mass move independently of the ovary? If it slides separately, it's more likely tubal. If it moves with the ovary, it's probably part of it, like a corpus luteum.
Practical tips. Okay, what about interstitial EPs? Less common.
Much less common, yeah. That's where it implants in the part of the tube that runs through the uterine muscle wall.
What are the signs to look for?
Absence of that sliding sign between the uterus and the sac. Seeing it clearly on a 3D coronal view. A uterine claw sign where myometrium surrounds the sac. Or seeing very thin myometrium between the uterine lining and the sac. There's also the rare interstitial line sign.
And definitely avoid calling it corneal EP.
Yes, please avoid corneal EP. That term is too ambiguous. It's been used for both interstitial EPs and IUPs in uterine horns. Stick to interstitial EP.
Got it. And cesarean scar EPs, we said they're now classified as ectopic. What's key there?
They're increasing because C-section rates are up, and they're high-risk uterine rupture, placenta accreta issues.
So precision matters.
Absolutely. Use the full term. Cesarean scar ectopic pregnancy, not just cesarean scar pregnancy. Follow the SMFM guidance. Diagnosing them can be tricky. They might look like a cervical EP or even a miscarriage in progress. The Lexicon points to other resources for the specific criteria.
Okay. And quickly, cervical and ovarian EPs.
Cervical EP implants in the cervix lining. Use cervical ectopic pregnancy, not cervical pregnancy. Ovarian EP is rare. Implants on or in the ovary looks like a corpus luteum often.
So how do you diagnose an ovarian EP?
You really need to see definitive signs within that ovarian lesion, a yolk sac, an embryo, or cardiac activity to call it an ovarian EP. Otherwise, it's overwhelmingly likely to be a corpus luteum.
Makes sense. Be very sure for ovarian EPs. Okay, the last location category. Pregnancy of unknown location, or PUL. What's the definition now?
PUL is when you have a positive pregnancy test, so elevated HCG, but the transvaginal ultrasound shows no evidence of either an IUP or an EP, not even probable signs.
And what could it be?
If the HCG is still relatively low, say under 3,000, it could be a very early IUP or EP that's just too small to see yet. Or it could be a completed early pregnancy loss.
So follow-up is key.
Yes, tracking HCG trends and repeat ultrasound are usually needed. Importantly, the definition holds. If you see any signs suggesting a probable IUP or a probable EP, it's not a PUL.
Okay, PUL means truly nothing seen on ultrasound despite a positive HCG. That clears things up. Now for the final and very sensitive category, early pregnancy loss, or EPL. Sounds like big changes here.
Yes, this is a really important shift towards clearer, more specific, and hopefully more patient-centered language.
What was the old terminology?
Well, back in 2013, the SRU set criteria for things being suspicious for or diagnostic of pregnancy failure. Those ultrasound criteria themselves haven't changed.
Do they?
But then in 2018, ACOG started using the broader term early pregnancy loss, EPL, and noted that spontaneous abortion and miscarriage were often used interchangeably.
And patients prefer.
Surveys show many patients find the word failure quite negative and prefer miscarriage. So a big goal here was to adopt language that's accurate but also more compassionate.
So early pregnancy loss, or EPL, is the main term now.
Yes. It's the central term, and it's used with 5 different modifiers to describe the specific situation.
What are the 5 modifiers?
They are A, concerning for EPL, B, diagnostic of EPL, C, EPL in progress, D, incomplete EPL, and E, completed EPL.
And can you still use miscarriage?
Yes, miscarriage or spontaneous abortion can be used as alternatives for EPL in those phrases. If spontaneous abortion is used, they suggest adding a note saying it means the same as miscarriage, just for clarity for patients.
Okay, let's walk through them. What does concerning for EPL mean?
This replaces the older suspicious for pregnancy failure and also IUP of uncertain viability. That latter concept is now better termed IUP of uncertain prognosis.
And why concerning instead of suspicious?
The panel felt concerning conveys the right level of worry or caution without being quite as harsh or potentially alarming as suspicious. It's used when the ultrasound findings suggest the pregnancy might not progress, but they don't meet the strict criteria for definite loss yet.
So it indicates risk, but not certainty.
Exactly. And they also mention other subtle signs linked to poor prognosis, like a calcified yolk sac or an expanded amnion, directing you to the literature for details.
Okay, what about diagnostic of EPL? That sounds final.
It is. This replaces diagnostic of pregnancy failure in old terms like blighted ovum or non-viable pregnancy. It means the specific, evidence-based ultrasound criteria for confirming a loss have been met.
Like what?
Like seeing an embryo of a certain size, CRL 7 millimeter, with no cardiac activity that's embryonic demise, or no cardiac activity in a fetus, GA 11 weeks, fetal demise, or seeing a large empty gestational sac, MSD 025 millimeter, or no embryo appearing on follow-up scans that's an embryonic pregnancy.
Clear criteria for diagnosis. What about EPL in progress?
That's when you see the gestational sac down low in the uterus, in the lower segment, or even in the cervix, looking like it's on its way out.
What if there's still cardiac activity?
Then you have to consider if it could be a cervical or cesarean scar EP that's maybe starting to expel. Seeing the sac move either on its own or with gentle probe pressure, that sliding sign again confirms it's not implanted there but passing through. Sometimes you might see increased blood flow up higher where it originally implanted. Follow-up is wise if unsure.
Okay, that's the process of loss. What about afterwards, if not everything has passed?
That's incomplete EPL. It's the preferred term for when there's still pregnancy-related tissue left in the uterus. You might see thickened endometrium, often with blood flow inside it, or maybe a persistent gestational sac.
Are terms like RPOC still used?
Yes. Retained or residual products of conception, RPOC, is an acceptable alternative. Or you can just describe the findings like thickened endometrium with vascularity. The panel discussed maybe dropping retained from RPOC, feeling residual might be softer, but kept it because it's widely used, especially for pathology.
How do you know if it's incomplete?
An endometrial thickness under 10 millimeter makes significant retained tissue less likely. Seeing vascular flow within the endometrium makes it more likely. Avoid terms like intracavitary embryonic tissue or fetal tissue.
Good guidance there. And the final one, completed EPL.
That's used when ultrasound shows the uterus is empty, suggesting complete passage of the pregnancy tissue. You can be more confident using this term if a previous scan had shown an IUP, or if you're considering it as an outcome for a PUL.
So those 5 categories cover the spectrum really well. There was also a mention of enhanced myometrial vascularity.
Right. That's usually a normal temporary finding after an EPL, either incomplete or completed. It's just some increased blood flow in the uterine muscle wall deep to where the pregnancy was.
So, not something to worry about.
Usually not. It's important to recognize it so you don't mistake it for rare, serious things like an AV fistula from a DNC or a congenital AVM. It's different from subinvolution of the placental site, which is a pathology diagnosis.
Okay, usually just part of the healing process. Well, this has been incredibly thorough. What are the main takeaways from the article's conclusion?
They really stress that this field is still evolving. First trimester U.S. terminology is relatively new and will change as technology and understanding grow.
Makes sense.
They strongly encourage adopting these new terms and ditching the old confusing ones like fetal pole, pseudosac, angular pregnancy. They have helpful summary tables in the paper showing what to use and what to avoid.
Key shifts.
Replacing pregnancy failure with EPL and its modifiers. Replacing motion heartbeat with cardiac activity and avoiding living viable. Redefining EP to include cesarean scar EPs, and keeping the original strict definition of PUL.
And the ultimate goal.
The hope is that widespread use of this lexicon leads to communication that's clearer, more logical, and importantly, more respectful for everyone involved in first trimester pregnancy care. They acknowledge all the work that came before and expect this lexicon will also need updates in the future.
This really has been a fantastic deep dive. It's so evident how this standardized terminology isn't just about medical accuracy, though that's critical, but also about clear communication between all of us clinicians and being more sensitive in how we talk about these often difficult situations with patients.
Absolutely. For anyone listening who's involved in radiology or learning about it, really getting comfortable with these terms, knowing what to use and what to avoid, will definitely sharpen your report interpretation skills, improve how you talk with colleagues, and ultimately help you provide better, more compassionate care.
Definitely. So as a final thought to leave you with, consider how this evolution in terminology reflects not just our growing biological understanding, but also shifts in how we approach patient communication and care itself. What future changes in radiology language might we see down the road, and what might those changes signal about where our field is heading?